So by now, I'm hoping that you've heard about the brand new Podcore subscription that Speech Therapy PD has rolled out. For $79 a month, you get over 175 hours of ASHA continuing education with 19 new episodes a month. That's fantastic. Well, they want to make sure that you also know we have a brand new coupon code. So the coupon code is F as in first, B as in bite, followed by the number 20, FB20. And that brand new coupon code will give you $20 off the Podcore subscription. So you get 175 hours of continuing ed plus an average of 19 new hours a month, all for $59 a year. And we cover everything from early intervention to schools to adults to ethics. So be sure to type in F as in first, B as in bite, and then the number's 20. Enjoy your coupon, or as my kinfolk say, enjoy that coupon. Hi, folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by SpeechTherapyPD.com. I am your host on this nerd venture, Michelle Dawson, MS CCC-SLP CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. All right, y'all. So Erin and I decided to wrap out the crazy train that has been 2020 by tackling a topic that has been on our hearts. Y'all, the last few weeks, Erin and I have been having a lot of conversations that were inspired in part by my wicked stepmommy, Mama Lisa. Please know that the wicked part is only a joke. Like, she coined it when I was like 12, but it's a little one part, but just a little. But this is family fun. Anyway, y'all, my Mama Lisa can drop the pearls of wisdom. And lately, she has been sharing about how important it is that we protect our energy. So why? Y'all, we're in the business of healing, often because we are empaths, and that's sort of what an empath does. People find us, they seek us out. Yes, for speech therapy, but have you ever noticed that when your friends are heartbroken, or your coworker is stressed, or you just happen to be standing in line at the grocery store, but yet you can just feel the person in front of you just needs a good cry, and the next thing you know, you're talking to them and maybe pre-COVID hugging them, maybe pre-COVID, post-COVID handing them a tissue. Anywho, they find you. Why? Because you can speak joy and healing into their hearts, and that is a blessing and a gift. But y'all, it can also cost you your energy. And Aaron and I have had a few cases over the last couple months that no matter how we went about planting a seed or trying to cultivate it, it just cost us our energy. And it made us realize that we need to do a better job of placing emphasis on setting up boundaries so that we share our skills and gifts while also conserving parts of ourselves, some of our muchness, so that we can still be the best that we can be for ourselves as well as for our families. So that got us thinking about how this pertains to the world of SLPs in general. And one late afternoon porch conversation, because I truly think porch conversations in the fall, they're just perfect. Well, one afternoon there, that led us to Erin and I here to wrap out 2020 with. So, Erin, how are you doing? My nose sounds slightly better, but I did have a massive sneeze attack be courtesy of me eating a fair amount of mayonnaise on my grilled cheese sandwich. Don't judge, it's delicious. But how are you?
I'm good.
Y'all, this
All
has been
things considered, I'm good.
oh, oh my God. Just making it to the microphone today has been a comedy of errors, and we both had technical glitches and lost a couple tracks, but we're fine. We're thriving.
We'll get there eventually.
Yes, one day we'll adult better, but que sera. Oh, oh my goodness. Okay. So y'all, if we have to say thank you. This has been a bizarre several months by any description possible, and we are so grateful to have been on this journey with y'all, and I am in awe of our profession's ability to step up and succeed in the face of turmoil. And there was many areas of turmoil, but also many areas of growth and harmony this year. So I don't want to focus on the negativity. I want to focus on the positivity, because um I know for 2020, as awful as it was also, I mean, Pack Dawson had some great things. Bear can wipe his butt. Goose can hold his pencil correctly. There was some fantastic accomplishments in our household this year. So, how about for you, friend? How did this? How you doing?
It's been a year.
Yes,
A
you
lot
bought a
has
fanny pack.
changed.
I'm just saying that's huge in my
I bought
opinion.
a couple fanny packs,
Oh my
but
God.
that wasn't quite what I was gonna go with for the highlight of my year.
But they make me giggle because I'm so old. I was there when they were there the first time. I'm sorry.
They're so functional.
Huh. Yep. Anywho, sorry, I just had to end 2020 with your fanny pack editions. That's just great.
Highly
Uh,
recommend them.
yes. Okay, wait. But also, I just have to say we are ending 2020 on a amazing note. Y'all, it is, in case you didn't know, this is Pediatric Feeding Disorder Awareness Month. So please head over right now, as long as you're not driving, and follow Feeding Matters, because of their Feeding Matters is the lead international nonprofit, interprofessional, practice driven, family focused, also amazing. I don't even know the word I'm looking for, because it's been the end of the year and my brain's fried. They're the gurus behind the fact that effective October 1st, 2021, we will have a standalone R code in the ICD framework for pediatric feeding disorders. And all of that culminated in 2020. And that means for the patients that we serve next year, we can accurately give the ICD-10 code or ICD-11 code for what they're struggling with, and that will open so many doors. So I think that is one of the greatest things this year has done for the patients that we serve. So thank you, Feeding Matters. Thank you
Mhm.
for Pediatric Feeding Disorder Awareness Month.
Which South Carolina adopted.
Yes, but you said it earlier. You said we were one of how many?
4.
4.
4 states. That's huge.
We did something right. We did
Mhm.
so we're normally South Carolina is not at the top of the list, and if they are, it's not the list that you wanna be on, but this time we are at the top of the list, and it was Arizona and South Carolina, and I don't remember who the other 2 were. I feel like it was in the Midwest somewhere, but go on.
Yeah. I forget. Pennsylvania's an almost, I think.
And almost, that's huge.
An almost.
Yes. Okay. All right. So, well, we have a lot to cover this evening because we are talking all things scope of practice. So, in the broad sense, dear friend, can you please rattle off to us what the ASHA Big Nine are that is encompassed within our scope of practice?
So we have articulation, fluency, voice and resonance, receptive and expressive language, hearing, swallowing, cognitive aspects of communication, social aspects of communication, and then communication modalities,
AA.
aka could be AAC, any form essentially. But those, it hasn't been that long since I've taken the praxis, so those are ingrained. But all very broad too. I mean, not all encompassing, but all very broad because we have to know and across the lifespan because we have to know all the things.
So here's where the conserving of the energy comes from. All right. So, big picture, when you graduate, honestly, an individual who has most recently graduated, they're at the top of their game to be a generalist. And there's a lot of beauty in that. I mean, a recent grad knows way more than I do about best practice for aphasia treatment or best practice for fluency because those are not things that I treat.
Mhm.
Y'all know more than I do because you're at the top of the game for knowing a little bit about a lot, right?
Mhm.
I will eat the humble pie and say, when I graduated grad school and started my CF, I was like, I know all the things. And I didn't know diddly friggin' squat, but I thought I did, which is very, very dangerous to be that optimistic about your capabilities when you enter your CF year. I'm glad that I had amazing mentors who shaped me and constructed the basis that has been my career to basically say, "Oh yeah, honey, but you really don't know." But they did so with like a bow on top, so it was more acceptable, right? Palatable, so to speak. But over the sense of your career, your unique scope of practice changes. And you can find more about what a scope of practice is on the ASHA website. You can just type in scope of practice. But one of the reasons, there's 5 main reasons why we have the purpose of the scope of practice. One is to delineate areas of professional practice. 2, and I'm reading straight from their website, folks, to inform others, i.e., our professional colleagues, about our roles and responsibilities as qualified providers, also for the general public, so that there's no mass confusion on what our scope is. 3, to support SLPs in the provision of high quality evidence based services. 4, to support SLPs that conduct research and are in the process of disseminating their research. And 5, to guide the educational preparation and professional development of SLPs. So, like grad school, undergrad, to provide safe and effective services. So, we have to have a clear outline of what it is that we do and do not do in order to so that there's no mass confusion that we are, I don't know, an occupational therapist or a teacher, right? Our scope of
Mhm.
practice is then embedded into licensure within states, right? So you have your national certification, and then your scope of practice is adopted by states. And interestingly enough, your state has to update their licensure periodically to ensure that it is still in line with current best practice. For instance, with the SLPA certification coming through, with dysphagia is in our scope of practice, but if your licensure has not been updated in 30 years, your state licensure may not reflect dysphagia as detailed
Right.
as it should. Yeah,
Hmm.
that was a lot. I get testy over this.
Well, but I think a lot of people know the Big Nine and know what um practice looks like in that way, but there's so many other domains of our scope of practice that I think people forget about or they don't know about, or is just something that we need to be better advocates. I mean, for professional practice domains, advocacy is one of them, supervision, education, leadership, and research. So different ways that you can practice opposed to just treating. Not just that just treating is just treating, but supervise, as you always talk about, supervising students, supervising CFs, having leadership, which I think is something that is not as ingrained in us as students, especially when you work in a field where it's like one-on-one, you're focused on the patient. I don't think most speech therapists are properly trained to be admin leader. Like
Hmm.
a much more I think you should undergo other training prior to becoming a leader or manager.
Hmm.
Because so yes, I think there are certain people that have natural qualities, like natural leadership qualities that people want to follow, and there are characteristics that al- facilitate someone being a better leader, but from like a management standpoint, that's not necessarily intuitive. But it's assumed a lot of times if someone's a good clinician, they'll be a good manager, and that's not always the case. But it's also not their fault a lot of the time because they don't have training.
Yep. Nope. That is all accurate. And that is accurate. Also, we're still in a stage where most of us, if you've had a director of rehab, often your director of rehab is typically a PT and typically male.
Mhm.
Um, that is problematic, in my opinion, because unfortunately, the PT scope of practice and how they go about treating is so very different from the world of speech pathology. Like PTs, you may have 3 sessions going concurrently or overlapping in like the big gym. Because normally there's like at a rehab facility, there's like the gym, little gym, big gym kind of thing. And with speech pathology, we typically do not have 2 or 3 sessions going concurrently. Normally, you have
Mhm.
either a group session or you have one on one sessions, but they typically don't overlap. And those very ingrained differences can make it difficult for PT managers that are not familiar with it to understand why our productivity is so different.
Mhm.
And we need, just as you explained, we need to cultivate our leaders now, especially if you're in the position where you're supervising students or you're mentoring a student. That's your opportunity to say, look, we can lead by example. Let me show you different opportunities or courses that you can take to make you a future leader of our profession. On that note, the Minority Student Leadership Program and the ASHA Leadership Development Program, y'all, I highly, highly recommend those. And numerous states are starting their own state association leadership programs. So please,
Mhm.
please, please look at those because y'all, you're our future.
Yeah.
Soapbox done.
Um, I also my favorite part of our scope of practice is our domains of service delivery,
Mm.
because so there's 8 different domains and they are counseling, prevention and wellness, screening, assessment, treatment, modalities, technology and instrumentation, and then population and systems. So there's 8 of them. Treatment is one of 8, which, yes, most of us are treating, most of us are assessing. But a huge part of that is collaboration.
Yep.
and creating a collaborative culture, which is something that takes work to do. It doesn't just happen. You have to build those relationships, but that's a huge part of what we do and a huge part of our scope of practice. So just remember that all of these things are written in our scope of practice. Some people may also forget this one called counseling. That is 1,000% in our scope of practice.
Say
I
it
am
again for the people in the back.
I'm just
Woo!
going to tell, like, I have been professionally frustrated when people have said to me, "That is not my scope of practice to be counseling this family." If it is something that is impacted by their communication or their feeding or swallowing difficulties or anything that you're treating, like, yes, you have to be very careful. If mom is going through a hard time or the family is going through a hard time, um, you need to know when to pass them over to a psychologist or give them resources that they need. But when it comes to discussing with the family a possible diagnosis, how they're feeling about it, how feeding is impacting them as a family, how they're advocating for their child and what they need, that's all within our scope of practice. And I think that's something that, I mean, I was lucky enough to have a counseling class in grad school. I was also lucky enough to have a psychology degree and have taken a lot of counseling classes. So it may come more naturally to me than other people, but I'm very passionate about that because I love the counseling aspect of what we do. And if you are bypassing that, you're missing helping your families in certain ways. Um,
That Okay, so this is where in the world of early intervention, we should not be doing direct service delivery. We should be engaging in coaching because a huge component of the coaching model is counseling. It is
mhm,
seeking to understand where, which gets us back to why we were so tired and we had to pick up this conversation earlier. It's seeking to understand where is the communication, where is the breakdown in your day, and how can doing feeding therapy, how can setting referrals to the different specialists, how can bringing in an AAC device, how does that help the family? And yes, we do have to model how to engage the device, but you can also do that by explaining to the family, counseling the family on what actions and what steps they need to take, right?
mhm,
And that gets back to the counseling piece because I remember when I was in grad school there was so much drive on data collection, like the ability to, are you doing
mhm.
pluses or minuses, are you doing tally marks?
I'm
Also,
really bad at data collection.
yes, but when you're doing counseling and you're engaging in the coaching perspective, you're not rapid firing out tally marks and doing aggressive data collection. You're having an open dialogue with the family
Right.
and you may make bullet points on, hey, I need to make a referral for them here. But in your arsenal of referrals, in your theoretical bag, because I hope that Erin and I have convinced you to leave your physical bag at home. But in your theoretical bag, you should have in your ability to make recommendations for the family caregiver trainer support through Feeding Matters. You should be able to make recommendations or know how to pick up the phone with the family present and call the pediatrician and make a request for OT, PT, allergy, GI. The list goes on, right?
Mhm,
But and again, that's also in our scope of practice. Hold on, I gotta pull this one up because this one I chased down this one. Our scope of practice is it goes out even farther. Okay. So yes, we have the grand overall particular scope of practice of the speech language pathologist in general. And you graduate and you're a generalist, right? And then you start working. And maybe you come out the gate and you know exactly what you want to do. I came out the gate and knew I wanted to do dysphagia. So I took every single Bonnie Martin, Dr. Bonnie Martin Harris class I could get my hands on. And then we moved to South Carolina and I went from treating dysphagia in adults to dysphagia in peds. And those are two totally different things. And then I had to start taking all of the courses. That action, I changed my unique scope of practice. And that's where it gets very, not convoluted, but very, very particular. We have to practice within what we have the skill set for. Okay. So if you are engaging in speech therapy and you're switching from one field to the next, yes, it is within the grand scope of practice of speech pathology, but you can't jump straight from peds to adults without additional coursework because then you are practicing outside of your area of competency. That's the
Mm-hmm.
word that I was looking for, competency.
Yeah.
So, at at our university, we're setting up a transgender voice program. I am helping to set it up in the sense of I know how to network within the community and write flyers and do those kind of things. I It is inappropriate for me to treat because I don't know how to.
Mm-hmm.
So I'm going to be champion from the sidelines and making some pretty bulletins, but I can't ethically treat what I have not taken courses in,
Right.
right? So that's not in my personal scope of practice. So, yes. Okay, well, what are your thoughts there, lady?
About personal scope of practice?
Mhm.
Um, I think that as like you said, especially as a new clinician, you're kind of expected to be a catch-all, and I think it's important to feel comfortable. Like, you don't wanna lose all of that. I think it's important to try and be comfortable treating a variety of patients and a variety of diagnoses, but at the same time, I know that the more that you find your niche, the more you want to explore that and you want to grow that.
Mhm.
And what I struggle with is I am a perfectionist and I like to do what I'm good at. So
Sorry.
I like to it's shocking. I'm a I'm a procrastinating perfectionist, but I'm a perfectionist and I like to do what I'm good at. So I like to treat the patients that I'm good at treating. But then what happens to me is I'll get a patient and I'm like, I'm not good at this. I'm not bad. Like I'm still doing a good job, but because I have the patients I love to treat and I feel comfortable and I've taken all this continuing ed in, when I get another patient, I'm like, I feel that much worse about it, but I think sometimes it's good for me to continue to just keep up with some of those skills. Like, I'm not great with articulation. I'm not great with fluency. A lot of times if I get those kids, I will usually with the clinic I work in is really great about everyone, we have such a variety of interests. And so it's not that I don't want to treat certain patients or that it's more so like I'll get a patient and I'm like, oh, this therapist would be so phenomenal for them. They just give them better care. It doesn't mean I can't do it, but sometimes, I mean, I want the patient to get the best care that they can.
Yes.
But you can't always do that. I mean, there are people in rural settings that they're the only therapist, and you're going to have to treat everyone.
Mhm.
And that's, I mean, it's within our scope. And at that point in time, though, that is what's best for the patient because it's either you or no one. But
Yep.
if there is someone available that can better treat this patient, I think that's fair.
That was me and my CF here. I was literally the only one for like 45 minutes in every direction and I had to treat everything and thank goodness I was at the top of my A game as a generalist.
Mhm.
Um but I mean, I it is hard to say no, but you have
Mhm.
to be able to say no. And that's what we're driving at here. Your It is expected and desired that your scope of practice will change over the course of your professional career, right? Um, we had on, oh my gosh, a year and a half ago, we had on a sweet lady on talking about dyslexia. And the two things that she treats are dysphagia and dyslexia. Pediatric feeding disorder, dysphagia, and dyslexia. And I was like, how in the blue blazes did this intersection come to pass? And she was like, well, she was like, I was the only one. She had some personal experience with engaging with little ones who had dyslexia. And so she had to learn it. But I mean, how cool is it that she had gone in one direction and then all of a sudden this new problem arose and she took the extra um,
Mhm.
Gilliam and then Orton Wilson.
Or in no, or in Gillingham or something like that. You guys
Okay.
tell we're big orthography people.
Yes.
Or in
I,
Gillingham, I think is right. I don't
okay. And then something Wilson Readers. There it is, Wilson Readers. My when Goose was like 3, my mother-in-law was like, "We need to get him started on the Wilson's reading program." She's a special ed teacher, and I'm like, "No, he's 3." Like, I just want him to pee in the pot. We got plenty of time to worry about literacy later on. Oh my god, if she's listening, I'm so sorry. But like this
Yeah.
the point is your scope of practice will change. Now, here's where when you want resources and you want help, help is there. Okay. So Ash's practice portal, on the practice portal, it talks about specific scope of practices according to locations and settings. And there are scope of practice guidelines for an early intervention SLP that are different than a scope of practice guidelines for a NICU SLP, right? And it talks about what you need in order to practice within that setting. What are your baseline, what am I looking for here? What are your baseline competencies? Like what do you need to know in order to work there? And that's fantastic information to have, because once you have those guidelines, or if you're thinking of a career change, say you're working in early intervention right now, but oh by the way, now you want to switch over to a NICU, which a lot of people do. Not
Mhm.
me. Knowing what you need to know in order to make that dream come to fruition. Hey, if that's your goal for 2021 is to go from EI to NICU, then check out what the scope of practice recommendations are and then take the courses in order to see yourself and your future patients become successful. Right?
Mhm.
Yes. And
Yeah, I
being
mean that can, like you said, that there's continuing education for a reason. It's to grow in things that you already know and to grow your knowledge in those areas, but it's also to grow knowledge in other areas that you want to expand on. I think about it in what do my patients deserve? I mean, if I have a patient that I feel like I don't have all of the knowledge to treat them, I'm going to find it. I'm going to,
Mhm.
if you know, I'm going to educate myself. I'm going to take courses. I've recently been taking more courses on like regulation and floor time and different kind of strategies to work with some more patients that I've been seeing, but that's just how you grow and change and develop. And and I think that your scope of practice doesn't necessarily have to be defined by the big 9 either. There are types of populations, and you and I talk a lot about, we're both empaths, and we look at patients differently than maybe some other people would. And sometimes what I view as my scope of practice doesn't make sense to other people. But I know, like, you and I know which patients are our patients. Like, I
Yep.
will see a kid in the waiting room and I'll be like, someone will be evaling them. I'm like, so
Mhm.
what's going on? Can
Yeah.
I see them? Like, you just know. And then from a, and I had a really hard conversation over the weekend, not hard conversation, but I've been I think we all can be really hard on ourselves, and I want to be able to help every kid. But I'm learning a lot, especially from like having OT mentors about what why certain patients affect me in certain ways and why other ones don't.
Mhm.
From my own sensory and regulation issues and my own profile to my patient's sensory profile. Like I'm learning a lot about how I react to certain situations and how some but and I don't know if this will make any sense, but I'm beginning to come into more of my own, even in the sense of there are some the reason why I'm not good with some patients is why I'm great with others. And so the skills and the relationships that I build and my reactions to certain patients are what make me be the perfect therapist for others. And so I think telling yourself sometimes it may not, this may be a feeding kid. I treat feeding kids, or it may be a kiddo that needs AAC and you're like, I do AAC, but sometimes there are family dynamics or certain um just other factors aside from what's written in paper in our scope of practice. And you're like, why is this not working? Or why is this working? And I'm not saying give up and I'm not saying don't ask questions. I always ask help, whether it's from an OT colleague, a speech therapy colleague, like getting their advice on how to better this. But there are other aspects to our scope of practice and what patients that we treat that may not be easily defined. And that was a long tangent, but why did I say tangent like that? Tangent.
I have no idea. That was a
Tangent.
very
That was
that
a
was a funny
tangent.
vowel.
But it's just I think the better that you get to know yourself as a therapist, it can be frustrating, and this may not make sense to a lot of people, but, like, I equate it to, like, when you get to know yourself and you're dating. The more I learn about myself, the less men there are out there for me because I'm like, I know myself too well, I can check you off so quickly, but I think the more you know yourself as a therapist, like, you find your I sorry, I've
No, that I mean,
but the more you figure out yourself as a therapist and you're like, "These are my kids, like, these are the kids I'm meant to treat," it does make you feel less capable of treating those other kids, which you are good at treating those other kids. You're just wonderful at treating the ones that are you're like, "These are my kids." So it's like,
yes,
don't and I do this. And I'll call Michelle and I'll be like, "I'm not good at treating this kid." She's like, "You are. You're just great at treating another kid." And this kid, like, you're doing a great job too. You're just being hard on yourself because it's not your top skill.
love.
Yeah.
And that's where we have to extend grace to
Mhm.
ourselves. Because my problem is I my personal failure that I carry as a clinician is that when I wholeheartedly feel that we need to be more aggressive in pursuit of medical etiologies
Right.
and the family puts a hard stop down or they're not ready to hear it and I get frustrated because I feel the pressure of all of the other ones on a wait list. And if I can't help your patient at this moment in time, because we're not addressing the underlying medical etiology yet, that is clearly there, that clearly needs some work. But I have others that are willing to do so, I get frustrated, right?
Mhm.
And so for me, that's where I feel like a failure. And what is the breakdown in the message that I'm giving? Where is my crucial conversation breakdown? And and that takes growth and emotional intelligence. And that's something that it is not outlined in our scope of practice that we need to obtain emotional intelligence. However, I truly feel that embedded within that counseling piece is emotional intelligence and maturity. And
Mhm.
that is, I mean, just by saying you need to work on one's emotional intelligence does not mean that you're going to save every single crucial conversation, because let me tell you, you're not, right? But I am able to recognize when I'm able to more quickly recognize when the message that I am delivering is not landing. It's not sticking, right?
Mhm.
And as I turn around and say right and then have word retrieval difficulties while I'm trying to come up with a better analogy for this, but it has pursuit of growing my emotional intelligence and those counseling skills by reading things like Crucial Conversations, by looking at, I'm trying to think of all the different books that I've read over the years, but
Mhm.
by expressing those pieces within myself, I am learning how to read the room and say, okay, well, this isn't the right time for right now.
Yes.
And
We
how to
talk about this, read the room.
Yes, you have to read the room. I mean, like, I'm doing this with Goose because he doesn't understand why Bear gets like, he's like, "Mom, I told Bear no," and he's getting frustrated with Theodore. And I'm like, "Baby, you are 8. Your emotional intelligence is here." I mean, because most people talk about this with their 8-year-old, right? And I'm like, "And your brother is a hysterical 6-year-old because they took away naps, thank you, COVID, in kindergarten." And that was a terrible decision. That might be a very significant poo-poo part of 2020 for Pac Dawson is there's no naps in kindergarten. So y'all, I have an emotional train wreck of a 6-year-old who needs to work on regulation when he comes home. But you know what? We focus on the green, on being in the green. And that really that visual cue helps. Unless he's in the yellow and he's like, I'm working on coming down. And we're all like, oh, thank you. This went on
Yeah.
another really bad tangent. But emotional intelligence and then being able to steer and say, at this moment in time, I am concerned I'm not fulfilling your need as your child's therapist.
Right.
So
A lot of times they will decide that.
yeah, and that's okay. I
Yeah.
had I just had this happen at work, but I could see it coming and I could see it
Yeah.
coming for weeks and with my private practice and I was like, I am not the right fit. I will not do 50 minutes of direct therapy and then turn around and do 20 minutes of parent education for a child where I don't speak their language nor do I have access to an interpreter. Like,
Mhm.
I cannot ethically do that. And so I explained that to the family. I explained that to the EI. I gave them recommendations on other private practices in the area that I know are going to tell them exactly what I told them. And then said, let me be your advocate with the LEA because the LEA will provide them an interpreter, right?
Right.
Let me advocate here. That went nowhere. But I made the offer and I did what I could, right?
Mhm.
So, peace of mind. Um, now the Tricky Wiki is writing all the documentation that is included in that conversational piece, but like peace of mind for the scope of practice.
Mhm.
Okay, so hold on. I've lost our other questions here. Okay, so I think we've beat the various scope of practice to smithereens, right? You can change your scope of practice. Your scope of practice should change over the course of your career. But how do we how do we go about implementing healthy boundaries to protect your scope of practice and to protect your energy so that you are still able to deliver services to the best of your abilities to those that are clearly within your scope of practice. Dun dun dun.
Well, I think that's a lot harder to do when you're younger. When you're new, I mean, I think it is harder to do because you I mean, I think a lot of us are people pleasers and yes people. And so when you're working in a clinic or you're working at a private practice or, I remember, like, I didn't really say no a lot my first year. I
Mhm.
would I would say yes to most patients that they would give me. I was a lot more vocal, I think, about the types of patients I wanted to see, but I was vocal too. Like I worked in a company that had a lot of EIs, so I was very vocal about what patients I like to treat. And it led to them referring those types of patients to me because they knew I liked them. And I mean, there weren't a ton of home health SLPs in the area that wanted to treat the most medically complex kids. But if I was asked to see a kid, even if I didn't really feel that I would be the best therapist for them, I don't think I really said no. I mean, can you like I think I think the struggle becomes like, yes, you have your own scope of practice. What what becomes what I think is important is having that continued conversation. Where I am now, there's a lot of conversations about what patients we want to treat and what populations we really like and what we find that we're best at. And so, from a scheduling standpoint, I think we do a good job of helping facilitate that for therapists so that they feel comfortable treating the patients that they're treating and that the patients get the best therapist for them. But at the same time, I think that you just have to be you just have to continue that communication. And the way I always phrase it is, what'll happen sometimes is a patient gets put on my schedule because no one else has openings. And as the course of seeing them, if I think I'm not the right fit or I talk to another therapist, like you slowly transition. And I always phrase it to either like the parent or my supervisor is I just think that this other person can give you more than I can give you. This is not my specialty, is usually the word that I'll use because I don't really call myself an expert in anything, but this is not my specialty. This is this person's specialty. Um, and you're just trying to get them to where they need to be because in reality, I just want my patients to receive the best therapy. I know there are also moments in time, there are times when therapists are trying to build their experience with a new population, or a lot of times we have people reach out that are trying to get more into feeding and swallowing, and so they may take a patient that is not fully in their
In their scope.
specialty at the moment, but they're learning and they're getting CEUs. I think if you're going to do that, you need to make sure that you have proper supervision and someone that you can go to ask those questions. I do not think it's appropriate for you to just wing it with some kids, especially for feeding and swallowing, because
Absolutely. That's
that
not
can be
ethical.
harmful. Yeah, that's not ethical. It is different. And where I am right now, there have been therapists that have wanted to dive into feeding and take on feeding kids, but I think we've done a good job of, providing education, getting them to continuing education, having them observe, and then there's always been someone with more experience there for them to ask questions. So I'm not saying don't treat patients that are not your specialty, but if you're going to do that, you need to have a path and have someone to ask questions to and someone you can lean on, because especially when it comes to feeding and swallowing, just because of all the medical aspects, and you can cause harm.
So, I will not call myself an expert because I think in order to do so, you need to have some more alphabet soup at the end of your name, right? Like
Mhm.
really truthfully. I don't feel that it's appropriate. I have done everything I can to take as many courses, and one day when I get over test anxiety, maybe I'll sit for a test that'll add alphabet soup. But y'all, test anxiety sucks. But years ago, I saw a subject matter expert. I saw Ms. Kaufman there talking about apraxia. And I remember there's room packed full of SLPs. She is absolutely a phenomenal public speaker. I sat there for 8 hours and it felt like two tops, right? I was so engaged with her presentation. And And she'd hit the point in her career where they were like, well, what if somebody calls you and they have a question and they just want you to treat fluency? She was like, I don't do that. And like so many people in the room had a hard time wrapping their brains around that. And she was like, you don't understand. This is the thing that I do. And I have built a reputation around it. So I will only treat that.
Mhm.
And she's built an excellent reputation around that. She is highly skilled at what it is that she does. And I thought, now that takes muchness to be able to say that and to be able to back it up and to be able to know it, right? And one day I hope to be able to do that. I mean, primarily that's what I do, but I also get AAC and I love that, right? But I what I loved about her statement was that it was immediately followed by, but I still get the kids that stump me. And I'm paraphrasing. That's a Michelle's version of what she said. She was like, but I still have to seek out and get referrals and make guidance and get guidance, right? And that's profound because we don't know what we don't know. I mean, how many times do I call you when I get stuck, or I call Leslie,
Mhm.
or I start making referrals for diagnostics because there's something else that's going on? So, my point is, you may hit the point in your career where people come to you because you are excellent in what it is that you do, but still be teachable, because that's an important boundary.
Mhm.
The moment that we close ourselves to the opportunity to learn, I that's that's scary to me. That's scary because that's dangerous, because we have to be able to be open to research that's changing. Um, yep. Sorry, I'm thinking we have a guest, y'all. We have a guest speaker coming on in March, and it's like a birthday present to myself. And her and I were talking about um, pathophysiology for growth and swallow. And I was just like, oh my God, I want to live in this woman's brain for like an hour. Because she had so much to teach. And
Mhm.
it was mind blowing. It was mind blowing. Yes.
Like, I think we're very lucky to have our village and our people that we
Hmm.
can go to and ask questions and, like, check ourselves,
Hmm.
essentially.
Hmm.
Yes, like, it is so important, and we're talking a lot today about, like, knowing your scope of practice and what you're comfortable treating and and being ethical. I always say, I was talking to a coworker the other day, and she was talking about a patient that she felt like had plateaued, or just it wasn't functional anymore what they were working on. And we I was like, trust your gut. Like, what is your, if you feel like you're not doing enough in the session, or if you feel like that this patient isn't progressing, or I always have those moments. And when those moments happen, I check myself and say, why am I feeling this way? Why is this feeling in my gut going off that's telling me this is not ethical, but this is not
That's your
something needs
compass
to
rose.
change. Yeah,
Hmm.
and I think we all have that, and that's important. And so all I'm saying is, when that moment happens, evaluate. Does this patient needs to be discharged? Should this patient be seen by another therapist? Can I not provide them what they need? Do I need to do some more education? Do I need to read some articles? Do I need to take a course? Do I need to reach out to someone that has more expertise? Because when that moment happens, just as in any feeding therapy session, when we talk about, or any patient that you're treating for any sort of diagnosis, like, if you do the same thing over and over again and you're getting the same result, like, something needs to change. So if you're getting that feeling and you're saying what needs to change, like, look at all of those different things and see what the possible outcomes can be. We're not saying don't just don't treat the kid. We're not saying say no to a patient because you don't feel like treating an artic kid, or you don't feel like taking on a stuttering patient. But, like, look ethically at what you're doing and use your resources and just do what's best for your patient within that scope and within what you feel comfortable. It is also valid to say, especially when it comes to maybe a feeding or swallowing patient or a patient that, if you're not super there are certain things where it's okay to say, I don't feel this is within my scope. I don't feel that this is something that I'm comfortable with, that I can provide them with the care that they need. That's also okay. But there's a lot of options out there. It's just important to process and evaluate the situation and not just jump in and say, "Oh, of course I can do this. I know everything. I don't need any help."
Said me 15 years ago, I got this, I'm totally fine. And then calling my dad on the way home, Daddy, I have no idea what I'm doing.
Yeah, this is not a podcast as an excuse to be like, "I just don't feel like treating this kid." No.
Yeah,
Like, if
no.
you can do it, you do it, and you figure it out, and you have your resources, and you help them. But again, it's just important to be aware of all of those factors.
Okay, so then another boundary that I have to set up is safety.
Mhm.
Okay. So I have gone to some questionable locations in my lifetime. Was at a patient's house one time and knocked on the door, knocked on the door, knocked on the door. There was a very large argument going on behind me. And the mom opened the door, grabbed me by my shirt, and pulled me to the ground. And she was like, "You probably shouldn't be here, Miss Michelle." Because gang violence was a regular occurrence. And we just hung out on the living room floor for until the shouting stopped, right? I have I have gone to people's houses to walk in on drug transactions, to which I was informed by the man at the door just to go straight to the back room and conduct my therapy session while they handled their business in the front, which I did a very excellent therapy session with sweat pouring off of my body, and then proceeded to thank them for their time and, make it safely to my car and, um, exit and call all of the appropriate people when my pulse had gone down and I was safe distance away, right?
Mhm.
Okay, so I say this because those are real life horrifying examples of personal safety. I made the contacts, I made the calls, and then to the latter situation, I did not go back, right? Because when you call 911 and DSS, it's probably not wise that you then turn around and go back the next week. That's a safety issue, okay? Clinician safety. Then there's also emotional, physical well being. And that emotional piece is tricksy. If you're at the point where when you are going to a patient's home or they are coming to see you, that you are having a stressful reaction or in response to the session, whether it be that they make you feel uncomfortable or you feel awkward about it, or I had a dad regularly make passes at me when I was there in the home with the child trying to do therapy. I mean, this was me 10 years ago, so pre children, right? And the dad would always hit on me when I came into the house. And I was so afraid because I was a new clinician where I felt like I had to say yes to all the patients. But that was sexual harassment. That was sexual harassment. But this was 10 years ago before it was okay to call it what it is now, right? How terrible is it that just 10 years ago I felt obligated to suck it up and deal with it until I was feeling physically ill going to their house, right? That's
Mhm.
not safe. And it is at those point in times where you need to have the conversation with your supervisors. You need to put in documentation. You need to reach out to the early interventionists, the service coordinators, and share those concerns
Mhm.
because that's a boundary. You
Yeah.
cannot treat that child under those circumstances to the best of your ability. And that is not patient client abandonment. That
Right.
is that is your safety. And this is why our documentation is
It's
critical.
so important.
And it's okay to say, this is not okay. And you don't have to follow it with, and I'm so sorry. Now, am I still learning to not say, I'm sorry? Absolutely. But I am a work in progress. And you're talking 30 some years of Southern female, like trying to come out of, right?
Mhm.
Wow. Almost 40. I mean, I know I'm only 37, but like we're coming down on me being able to
Don't
say
say
I'm
that
almost
because then
40.
I'm almost 30 and we're just not there yet.
Yeah, okay. We digress.
But
But
I is like you have to advocate for yourself is also an important thing. We're in a field where we help. We're in a helping field, and a lot of us are like people that just want to help others, and as a result, put our needs below them. But you have to advocate for what you need. I mean, I remember I had a family that like had cameras inside the house,
oh, I
and
remember
it wasn't until I know like, it wasn't until one day that the dad was home and I saw a different light on the camera that I realized that, like, when he wasn't home was when he was watching, and I was being filmed. Like, that's not we
without
should
your
be
consent.
notified without my consent, and that's not okay, and there wasn't really a policy, and I didn't feel like other people advocated for me in the same way. I said, I was like, "We need to have a policy on this. Why do we not have a policy on cameras?" Like, there at that point, you're like, "Okay, well, I'm gonna fix this." Yeah, because you have to think about it in the way too of if you don't protect yourself and you don't advocate for your needs, you're not going to be the best therapist that you are for your patients. So for those of us that need everything, that have a hard time being not selfish, but have a hard time just advocating for what you just need as a person, like you need to protect yourself to treat your patients to the best of your ability.
Yes, and that gets back to mindfulness.
Mhm.
And if you are not taking care of you in 2020, self-care is key. So, if you need to hear it, then I will say it. Pick up the phone and get counseling for yourself too. I saw a commercial on TV, which in and of itself is amazing because we don't normally watch TV that has commercials, but we saw a commercial on TV and it was a mom and it was a commercial for counseling and it showed a mom trying to juggle real world telework, teleschool, her husband coming home. They're like trying to throw dinner. Like it was a snapshot in my day. And at the end, she crawled into bed, and her husband was very loving and supportive in the commercial, and yada da da da. And she was like, "I just feel like I'm falling behind in all fronts." And y'all, it hit so hard and it hit so deep. And I just started sobbing because that's what I do. I just normally cry at commercials. Also, Cheerios. My God, Cheerio commercials always get me teared up. But and my husband was like, "Are you okay?" And I was like, "Yes, but that is what the last 9 months of my life has felt like. I feel like I'm failing as a clinician, as a wife, as a mother, as just a human and as a friend because I am trying to maintain what I tried to maintain 9 months ago. And I don't have to. We don't have to maintain the rigor and pace. And it is not only acceptable, but beautiful to seek out the guidance and support to fill your cup so that you can turn around and fill another's. So make the call and take care of you. Because if you're not taking care of you, then it doesn't matter that you've listened to us talk about what falls in a scope of practice and how to evolve and change your scope of practice, because you won't be able to engage fully in that scope of practice because you're still not a healthy version of you. So take care of you.
Mhm.
That hit really hard. That hit really close to heart. Okay, so know that y'all are loved. Oh my gosh, why am I crying? This is huzzah! You're fine. It's fine. Also, on a really great note, it took Christian 3 days, but he finally unclogged the toilet after Goose blew it up. So there's your comedic Pack Dawson moment because
Mm-hmm.
3 days. What did he put down that toilet? And do I need to take him to a GI? Oh my God. Okay, woman, final thoughts before I switch us over to questions.
I think you about covered it.
Yeah. Okay. All right. Know that we appreciate y'all. We're so grateful for y'all. And thank you for spending PFD month with us. Seriously, y'all, go be an amazing advocate for your patients and follow Feeding Matters. And thank you for spending 2020 with us. And we look forward to spending 2021 with y'all. So I'm going to go over to questions. Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.